Hi, class of BMI 598. My name is Frederick, and on behalf of Group 3, I'd like to welcome you to our presentation for the Fairview, Minneapolis Riverside TeleSleep project proposal. Our group consists of myself, Frederick, Tim, and Francis. I'll be presenting the first half, and then Francis will be presenting the second half. This project is a collaboration between Fairview and the Fairview Riverside Clinic and the University of Minnesota. And together, they're known as mHealth. And with this partnership, they are looking to provide new services and expand their service line. And therefore, our program is basically a TeleSleep program, which is to address sleep apnea. This is a state-of-the-art healthcare technology program. And this TeleSleep program is projected to serve the community of Minneapolis, which is over 500,000 people. And then that doesn't count the surrounding areas around Minneapolis. So the program has multiple goals. One being that Fairview and University of Minnesota want to expand their service line and brand, and essentially address this niche population of patients with undiagnosed sleep apnea. Number two, if these undiagnosed sleep apnea patients have their disease process addressed, we can reduce the costs from the chronic disease. Next, our program aims to increase patient access, especially since this is such a small program and sleep medicine physicians are difficult to find. In addition, to go to a sleep center may be very difficult, especially geographically. And then finally, we want to increase patient satisfaction. The issue with going to a sleep center can be challenging for some patients, and I'll detail why in the next couple slides. So our program is a three-part component. It's a telemedicine platform for patients to get to obtain the following. Number one, consultation services. So this means that you'll be able to speak with a sleep medicine physician and essentially conduct a consultation or a follow-up visit. This is essentially the virtual version of just going to see your physician in the office. Next is our most unique part of our program, which is the sleep study. And unique to sleep medicine, in order to diagnose sleep apnea, you would actually have to go to a sleep center and basically stay there overnight and have all your different metrics or measurements followed overnight. This includes, watching your heart rate, how you're breathing, your oxygen saturation, multiple different factors. And our program aims to bring that to your home or to the patient's home. And then finally, for sleep disorder treatment, once you're formally diagnosed with sleep apnea, our program allows remote monitoring of the patients through their CPAP devices. We hope to measure compliance and also address any issues in real-time feedback so that also increases compliance. We know that if issues are not resolved immediately, people tend to not use their CPAP machines. The other interesting part about our program is that we have an academic study component. The academic study component aims to basically serve as a proof of concept and an evidence-based research to demonstrate that telesleep medicine is viable and that it's non-inferior to going to a clinic to have your sleep study performed. And different criteria to come into the pilot academic study program are if a physician suspects delayed sleep phase syndrome, insomnia, narcolepsy, snoring, restless leg syndrome. Any of these could have them be included into our program. So we have the control arm, which is essentially your routine going to the sleep center or seeing your sleep medicine physician in the office. And then the experimental arm, which is essentially the telemedicine program. For the inclusion criteria, we're going to limit our patients for the academic portion of the study to 30 miles. This is to help deal with any insurance issues, as well as if we need to troubleshoot any issues during the remote monitoring process, we can geographically be able to deal with these issues. However, the overall program, we do aim to expand to other locations such as other local surrounding states such as Wisconsin, which is fairly close geographically to Minneapolis. From the exclusion arm, we're going to exclude any patients who are outside of the 30-mile radius if they're in hospice. And we'll also be performing a screening for any non-compliance. So if they meet that, then they will be excluded from the program, although they could still go through our normal program services. So to talk more about this program goals, we need to talk a little bit about sleep apnea. And this is essentially important because, believe it or not, sleep apnea affects 30 million people. And of that 30 million people, most of them don't even recognize that they have it. It's usually 80% is undiagnosed. And so unless their partner tells them that they're snoring or they observe them that they stop breathing while they're sleeping, the majority of people don't even recognize that they have sleep apnea. And therefore, our goal is to try to increase the amount of decrease the amount of undiagnosed sleep apnea patients out there by increasing patient access and and also through improved patient experience of the whole process. And if untreated, the patient may have chronic disease issues such as pulmonary hypertension, stroke, coronary artery disease, and other quality of life issues such as excessive sleepiness and low energy. So if we optimize the patient experience of being able to perform the diagnostic testing at home and not at a sleep center, we'll be able to increase the amount of people being diagnosed with this disease process. And there are many complaints when patient goes to a sleep center, such as the bed is uncomfortable, the room is too cold. There are so many complaints that causes patients to drop out of the sleep study. So we hope to aim that if it can be conducted at someone's home, then the ease of comfort of scheduling as well as all the environmental factors can be removed. Finally, the program goal also aims to demonstrate the reduction of patient costs and also to show initial break-even costs. So we'll detail that further later. So objectives and metrics, I've talked about the patient experience and satisfaction. Again, we think that if the experience and satisfaction is increased, then we'll be able to treat more people. And in order to objectively have measurement of this, we'll be providing patients a survey. The survey may include details about how their interaction with the providers and staff went, as well as any technology barriers and other ways to provide feedback to us. We'll compare the study arms between those who went through the telemedicine program, as well as those who performed the sleep study or sleep consultations over the normal physical visits. Next is one of our most important parts of our study, which is looking at any morbidity reduction. And so there's 2 points that we're going to focus on. One being that we want to see that if we are able to diagnose more people with sleep apnea and then put them on treatment protocols, either through CPAP or other treatment utilities or modules or plans, we'll see a reduction of 15%. And that's our big goal, to reduce any unplanned healthcare visits specifically related to a consequence of the sleep apnea. And so we'll also be using a metric on how the person's sleep apnea is doing. So this hypopnea index is a measurement of the severity of sleep apnea. So essentially how many times someone has an airway obstruction or basically stopping breathing while they're sleeping. The higher the number, the worse. So if we see a reduction in the points, then we'll know that we're achieving our goal. And then finally, cost reduction. We're hoping to reduce our costs by 15%. This is very important so that we can demonstrate proof of concept for other universities or health systems to be able to emulate or even take our model and put it in their own healthcare system. So what are the initiation steps? Number one, we're going to look at the equipment. We're going to detail that in a future slide. However, we chose Philips, and we'll first establish the software in terms of the virtual visits. Next, we also picked Philips to support our remote monitoring software. This is essentially a platform, as we'll have a command center to be able to perform our consultations as well as perform the remote monitoring for CPAP adjustments, and also if there's any alerting that we need during a sleep study procedure. Next, we're gonna look at our staffing. Staffing is important because we need to make sure that we provide adequate amount of physicians and ancillary staff as well as registered nurses to perform our program. And next will be the metric recording as well as the tracking process. So because our devices are quite expensive, we need to have a logistic plan to be able to track when we send these devices and make sure that we do not lose them. So that process will be designed for that workflow. And then also the objectives and metrics that I had previously discussed will be implemented, and we'll find a way to calculate this through our EHR as well as the telemedicine platform. Next, we have the staff training plan and development. This is important because, contrary to belief, usually telemedicine programs do not reduce the amount of staff members. Instead, we kind of repurpose their duties. So instead of they're doing rooming at a clinic, they actually will then be repurposed to run a virtual waiting room or collect pre-registration information in a different way prior to the visit. Next, we'll work on the patient randomization and study arms. So this is essentially the academic component. So we're going to talk to a statistician as well as recruit our lead investigators for this. And once we have that, we're going to formalize our criteria and then create the study arms. We'll start the randomization process during this time. Next, we're going to review the program with our hospital administrators and the medical board. The medical board will assist us in ensuring that our sleep medicine physicians are fully licensed in the appropriate places, including other states outside of Minnesota if we plan to expand to other states. Fairview does have some clinics in Wisconsin, so we anticipate that to be one of our spots. As well as we're going to speak to our hospital administrators. The hospital administrators will look over our financial and legal policies and procedures. Finally, after discussing with all the different support staff and executives, we'll do our final plan and review. Next, after the plans are set, we'll also quickly have our ethics board review the academic study component to ensure that we're properly performing a randomized control trial. We'll seek an institutional review board basically qualifications or approval for the project, as well as review any of our legal liability for the remote monitoring components. And then finally, for post-review, we'll discuss with our IT team to start installing the Philips software for our command center, as well as any other softwares on tablets and computers for the telemedicine clinic, virtual clinic. And then we'll finish the patient randomization process. During this time, we'll then provide informed consent forms to the patients to ensure that they understand that they're in this academic study, or if they opt out, then they go to our routine program. At this time, then we'll also have our staff finish their training. And then ultimately, during step 10, we'll perform patient education. This actually serves as two criteria. One is to actually do education to recruit patients into the study, or at least into the program. And then two, to also educate our patients in the community about what is sleep apnea and why it's important to diagnose these and treat this disease process. And with that, I will hand it over to Francis, who will present the second half. Thanks.
Thank you, Frederick. Now moving into the financial side, one of the biggest value propositions that we provide in our pilot program is that of convenience of testing. the opportunity to perform studies and care at home and consultations as well. So when you're looking at studies, uh, there's a phenomenon known as first night sleep. We all suffer from it, especially if you're going through a sleep study. That can severely affect the parameters and the data that's being acquired, potentially requiring more sleep studies throughout. By having the patient at home, you're mitigating that factor exponentially. And that is something, when it comes to efficiency on the financial side of it, that would be attractive in the program. And speaking of attractiveness and appealing, we're looking into brand recognition from two angles. We're looking at telemedicine and the concept of such. Studies have shown that telemedicine is that patients and customers are satisfied with the concept of telemedicine and the implementation of such. COVID-19 pandemic data and mitigation has required everyone to start implementing telework and technologies that support such. And applying those to telemedicine is not that hard, is not difficult at all. So you're already at a market that is expanding due to different reasons. And in addition to such, you're also looking into Fairview trying to provide state of the art healthcare. And when you're trying to implement both of them, what you get is a more appealing program for the market, which would be appealing for current customers and patients, and would be also appealing for future customers and future patients. When we're talking about budget methods, the methodology behind that, it's a little bit more complex, and we're going to go into detail for it as the slides go through. The main thing that we're looking into is mainly how much is going to cost for us to implement this program, and then the other side of it is how much are we going to get. So before we even start on that, we have to look into patients and the methods in which they would be part of the program, or they would be able to participate in the program. And that would be through either payment through cash or medical coverage. For medical coverage, we have an extensive list of the CPC codes and any kind of billing information that would be required for that to happen. And then for the revenue, we also have a study that will be shown later on. When it comes to expansion, like, we're not just looking at this program as a one and done deal and we're going to keep it as it is. No, we have an intent to expand, to increase the scale of the services that are being provided. That way they can actually reach out to more people and improve on not only Fairview's system and margins, but also quality of care for people surrounding the areas and throughout. So we already talked about staffing requirements, and that would be the cause that we would inquire when it comes to staffing. However, by implementing the program, we are capable of having a potential for revenue and a potential for efficiency and cost mitigation. So one of the big factors is that of sleep medicine alone, right? Fairview has the program already set up, and the reason for such is because sleep medicine has been acquiring a lot of attention in the past couple of years. In 2010 alone, we're looking at about 5.8 million visits for just sleep apnea diagnosis, 5.5 for insomnia, and you're looking for sleep medication prescription. The number of visits was around 20.8 million. So there is a market, and we're trying to acquire as much of the market as possible as we can without trying to inquire into more cost. So one of the aspects that this slide showcases is that of efficiency. Studies have shown that telemedicine visits and consultations usually take about 25 to 50% less time than your conventional traditional visits. So by adding that 25% logic into our 8-month plan that is about 32 weeks, considering the program would require 40 hours a week as an example, you're looking at a total amount of additional hours that could be billable or that are being saved of 320. So those 320 hours, the way we look at it, is additional hours that can be implemented into providing services to additional customers, or providing services to additional patients, or if anything, cost reducing the amount of hours that we have to pay for staff. So just for the angle from the angle of adding new consultations, new clientele. Just on consultation, a consultation takes an average of $250. Uh, if we were to use those free hours that we were able to efficiently deduct from regular consultations, and we add those amount of hours, and we just add the concept of adding a consultation to such, we're looking at about $80,000 additionally in revenue. So there's the potential of acquiring more clientele just by having the same staff, just by having the same amount of staff that we would have at a traditional at in-site service. And that is one of the angles that we're trying to convince for US a company to look into. The other one is that of cost mitigation. So uh, it doesn't show that much on this slide, but when it comes to cost minimization, you're looking from the angle of the customer himself, and you're looking at significant cost reductions due to secondary expenditures or expenses. Things like childcare, gas mileage. Those are secondary expenditures that the customer himself would not inquire if we are to provide a telemedicine program, which makes it more appealing for the customer himself, which increases the appeal of the program itself. And in addition to that one, we're also looking at reducing costs due to in-home nurse visits, because we have the telemedicine platform for such, we can severely or greatly decrease the amount of visits that a nurse has to do to potentially null. So we're looking into that level of cost reduction and cost minimization. And by increasing efficiency, we are lowering the amount of hours that we take, and that would be additional hours that could be billed into additional clientele, additional customers, additional services. So, when we're talking about technology platforms, there's a lot of criteria that we utilize, and our paperwork showcases that. But we just wanted to talk a little bit about the main things that we looked into. Obviously, there's a lot of regulatory agencies. The main ones is that of FDA, and there's different schools or different organizations that provide guidance into all these systems and implementation of such. The one we decided to follow is that of the American Academy of Sleep Medicine, which is, it seems like it's the most comprehensive one of them all, and it's kind of all encompassing. So one of the technologies, or the main technology that we aim to apply into our telemedicine pilot program, is that of Philips Telemedicine. They have a vast, they have a plethora of services, equipment, and software that focuses on interoperability and integration with the current system that the medical team might have. So that's something that we were looking for. We were looking for that FDA approval and compliance with HIPAA. And again, we were utilizing the margins of the American Academy of Sleep Medicine to determine whether or not these programs or these technologies are compliant, and in addition to being compliant, if they fit what we're looking for. So one of the big factors was the monitors, the sleep apnea monitors. They are meant to, they're supposed to meet standards of care that the American Academy of Sleep Medicine has set forth. They are supposed to record, or able to record, airflow, respiratory effort, and blood oxygenation, and the capability of it to transmit to a private cloud system in a secure fashion. That is something that we focus on and we try to implement. Uh, our best method when it came to software was that of outsourcing. So there's a lot of different technologies out there. One of the ones we were looking into was that of Sleep Care Online and Philips Medicine. We also looked into Vizia. We also looked into SnapMD and see if those options were viable for us. Once we start talking about legal policies and licensure, uh, the big factor we have to take into consideration here is that of the location, the setting that we're utilizing, and we're implementing this in Minnesota. Therefore, Minnesota law and state laws are highly important for us, and we are utilizing that to create a policy which covers and is compliant with those. Basically, when we're looking into coverage and reimbursement, we're looking at Minnesota state laws, sections 6 to A point 67 to 62A point 672, for example. We're also looking for accreditation boards that are relevant to the state of Minnesota. We're talking about the Minnesota Board of Medical Practice, for example, Minnesota Board of Dentistry, uh, and the Minnesota Board of Nursing, and also for respiratory care practitioners that are involved in sleep technologies. So our program and our policies are meant to be compliant with all licensure requirements, and our documentation is aimed towards covering everything that the state might need for proper compliance with documentation. Things like the type of service that's being provided, time of service, the basis for the provider's determination, and the effective methods of the service delivery, mode of transmission, location of originating and distant site, and the written opinion from a consulting physician. Those are things that we are making sure that we're covering, so we don't encounter any documentation slash billing issues. Another aspect that we're looking for is legal issues, going to that whole documentation, making sure we have all grounds covered. We're also taking legal consideration into controlled substances, which Minnesota statutes section 152.11 provides guidance. Remote monitoring practices, that would be something that we are aiming to mitigate. To mitigate such, we're looking at patient safety strategies by providing FDA guidance and product reviews, data management by storage, transmission, and collection, patient participation and consent forms for development and employment, and also an increase in cybersecurity. We're looking into covering all areas, as I've been constantly stating, for our program to be successful and us to not encounter any hurdles along the way or further down the road. And one of the aspects that we were looking for financially was that of expansion into interstate potential. So one of the things that we wanted to do in our program was to keep it keep it local, as some people might say. We're looking for patients that would reside in Minnesota. However, we're also trying to plan for the future, and we're looking into ways that we can actually expand the services to other places in Minnesota and other states or neighboring states. And for that, we're looking at the Interstate Medical Licensure Compact, which basically streamlines the licensing process for physicians and increases the accessibility of healthcare. Thankfully, Minnesota is one of the 30 states right now which participates in the compact, and they adhere to the Interstate Medical Licensure Compact Council, which that was a mouthful. That is something that we want to take into consideration for future expansion and future development of this program. This concludes our presentation. We highly encourage you to read our proposal, and we expand on all of the aspects that we discuss here. One of the biggest factors that we were able to develop was that of a proper policy that would govern this telemedicine program. In such, we talk about purpose, definitions for telemedicine, storing for technologies, telemedicine providers, and such. In addition to that, we also provide pretty extensive policy and procedures and concept forms and such. We look forward to hear from you. We hope that you take us into consideration for the implementation of this program. We're excited to work on this, and we are just striving for quality of care as well as efficiency in the medical environment and the sleep medicine field. All in all, thank you very much for your attention. Again, our group was composed of Frederick Chang, Timothy Forgey, and Francis Morales-Lozada. We thank you very much for your attention.